I'm Nick Vedder, the Chief of Plastic Surgery here at the University of Washington, and we're here for the 25th Annual Peter K. Buehler Lecture. As is tradition in plastic surgery, the year's annual lecture is actually chosen by the faculty. We rotate through, and this year's faculty who got to choose is Alex Gugatas, who had trained at the University of Pennsylvania. And it's tradition, we often choose one of our mentors, and that's what Alex did this year in choosing Dr. Steve Kovach, who was one of the most important mentors of his when he was a resident at the University of Pennsylvania. Dr. Kovach is an associate professor at the University of Pennsylvania in both plastic surgery and orthopedic surgery. He did his undergraduate at Penn, medical school at George Washington University, general surgery and research at University of Rochester, followed by plastic surgery training at Duke, and then finished it off with a hand and microsurgery fellowship at the prestigious Kleinert Institute in Louisville. He is internationally renowned in two areas in particular: abdominal wall reconstruction, which is his talk today, which I think was going to be very interesting to everybody in the Department of Surgery, as well as lower extremity reconstruction. And after this, he's going to talk about that to our group of plastic surgeons. He is the author of over 150 manuscripts, as I said, internationally renowned, and is also part of the vascularized composite tissue allotransplantation team at Penn, where they do hand and limb transplants. But we are very fortunate to have him here with us today to talk about a topic that, as I was just talking about with Hugh Foy in the back when we were younger, was a truly vexing problem. But the new developments in abdominal wall reconstruction have really been a paradigm-changing event, and so he's going to share some of that with us today. So, Dr. Kovach, welcome.
Thank you very much for that kind introduction, and it truly is a pleasure here to be the Buehler Lecturer at such an esteemed institution. So what I wanted to share with you today is really, my thoughts and sort of my journey on abdominal wall reconstruction and principles of success. As a disclosure, I am a consultant for Dave Bard. So I think many times when I'm giving a talk, people ask, well, why should a plastic surgeon care about abdominal wall reconstruction? And I think the abdominal wall reconstruction patient, there's many different physicians involved in their care, and I think as plastic surgeons, we're probably the most versed at taking apart the abdominal wall and putting it back together. So I think our input is integral to the care of some of these patients. And I think importantly, I view this as a public health problem. If you think about the number of laparotomies that are happening every year across the United States and across the world, there are hundreds of thousands of people getting midline abdominal surgery each year, and a significant portion of them are going to get an abdominal wall hernia afterwards that leads to significant disability, and we see these patients when they're suffering through it and want it fixed. So I view this really as a public health problem. And I talked to some of my residents in the past, and I said, this problem really is almost a silent epidemic. You really don't hear much about it. There's no ribbon that people wear on their jacket for ventral hernia, but it is an enormous problem that we face on a daily basis, taking care of patients in a clinical setting. If you think about the conservative estimates of who gets a hernia after midline laparotomy, conservative estimates are probably around 10%. Now those 10% of patients are generated by our general surgery colleagues, our GYN colleagues. Anyone who's approaching the abdomen through some type of abdominal incision can generate a hernia. I think that estimate is probably an underestimate. I think probably it's on the order of somewhere between 10 and 20%, which generates an enormous number of hernias to fix each year. If you think about 250,000 hernias that are getting fixed each year in the United States, then you put it into perspective to other common clinical conditions that we see regularly, prostate cancer and breast cancer. Both prostate cancer and breast cancer are on the order of probably about 230, 240,000 patients a year being treated. So it's on a similar scale in terms of magnitude, but I think sometimes it doesn't quite get the press and the attention that it deserves. As human beings, sometimes, unfortunately, bad stuff happens, and we had just talked before this about the concept of the damage control abdomen. And when you look at sort of where some of these challenging patients are generated and how they come to us, ultimately, it's pretty much even thirds. A third from penetrating trauma, a third from blunt trauma, and then a third just from bad intra-abdominal sepsis or bowel perforation, which generates some of these challenging patients for it. And this is a paper that our group published actually just this past January in the American Surgeon, and this really speaks to the scope of the problem in this country in terms of the magnitude, not only the number of patients, but healthcare expenditure and ventral hernia repair. And when you look at the trends they're only getting higher. We're seeing more patients with ventral hernia, but also if you look at the healthcare expenditure in dollars per year, it's approaching $5 billion a year in annual healthcare expenditure to take care of patients with a ventral hernia. So a significant portion of our healthcare expenditure is also going towards addressing these patients. And I think in Philadelphia and Seattle, the patients are similar that we see. Patients are getting sicker over time. And you look at the patients who are getting a hernia and then getting their hernia fixed, they have additional comorbidities. They're heavier, obesity is on the rise, they smoke, they have diabetes. So patients are getting sicker. It's a common condition, and complications when you look at tackling some of these challenging patients are quite common. And I'll share with you some of those complications and how we address them today. So my practice, a large portion of it is devoted to abdominal wall. So I end up talking to a lot of folks about abdominal wall, and sometimes someone will fix a hernia and they see me in the hall or outside of the OR, and these are some of the phrases that whenever I hear, I kind of cringe a little bit, just because I know most of the times we're not probably going to have an optimal outcome. There's no tension, so I just closed it. The classic tension-free repair where you inset a piece of billowing mesh without physiologic tension, not using mesh in critical size defects. And laparoscopic and robotic surgery, I think, have a place, which we can talk a little bit about, but I think if you can't do the same operation that you would do as an open approach and restore the continuity and the physiologic function and the anatomic arrangement of the abdominal wall, then we should probably do it open and not robotically. So really, when we see these patients and we see them in the office and we chat with them, I mean, these are the things really that we want for our hernia repair patients. We want the perfect mesh for reinforcement, strong, durable, able to be tolerated, putting it in a human being, and long enough lasting. With some of the newer products that are out there, the concept of the biosynthetic mesh that's going to go away in the course of a year is very intriguing, but the long-term data is lacking at this point. Primary fascial closure, we know across all degrees of contamination and scope of hernia is protective of hernia recurrence. Stable soft tissue, a concept near and dear to plastic surgeon's heart. We can't kill them with the operation. They have to have acceptable comorbidities. And at the end of the day, we don't want any recurrence. So these are the things that we know works. Mesh, autologous fascial closure, and importantly, anatomic position of the mesh, because just putting a piece of mesh in intraperitoneal mesh versus retromuscular mesh versus sub-onlay mesh is very different in terms of its recurrence profile. Interestingly, there's been a little bit of an evolution, I think, in the world of hernia with the development of some of the biosynthetics that have allowed a plane shift back to onlay mesh, which we'll also talk about. And I think, our main endpoint when we see these patients and we publish literature and we talk about our outcomes, our main endpoint always ends up being recurrence. And recurrence may not necessarily be the worst thing for some of these patients. And I think we're sometimes too hard on ourselves, because if you see these three patients, the patient on your left had a damage control abdomen after perforated vessel after cardiac catheterization. The patient in the middle had a single stab wound and bowel resection. And the patient on your right had a perforated colon after attempted laparoscopic gastric bypass. And these patients have the same endpoint, but they're coming to the table with many different things, but our measurement at the end is the same. I would say particularly for the patient with a perforated viscous gastrostomy tube colostomy, the endpoint, which would be a home run, would be restoring bowel continuity, getting rid of her gastrostomy tube, fixing her hernia in some meaningful way, getting stable soft tissue, and then if she has a recurrent hernia at a year, which it's likely she will, fix it in a more durable fashion. These patients really come from all walks of life. Hernia doesn't care about your socioeconomic status. This gentleman happened to be a very wealthy banker in the city of Philadelphia and had a cardiac catheterization that unfortunately went awry, and he's now about a year out after his damage control abdomen. As you can imagine, this can be a very debilitating condition for patients. It's very challenging for him on a social and professional basis to have this hernia and go about his daily activity, and you can imagine he's pretty desperate to have it fixed. And he's a good example of sometimes we need to do this more than once, or potentially our endpoint of recurrence is not necessarily the most meaningful measure. I fixed him once with a bridging biologic, closed the soft tissue. He unfortunately developed a fistula, had to go back and reoperate, managed to close his fascia primarily with mesh reinforcement. This is him at a year after two operations, a year after his second operation, and he now has a stable abdominal wall. So there's a litany of hierarchy that really affect our outcomes when you see these patients. What kind of mesh we're going to use, importantly, where we're going to put the mesh reinforced closure, getting the fascia closed, and then the other clinical judgment that is somewhat nuanced when we see these patients in the office, which is surgical judgment and technique. And I think the one theme that we see throughout the published literature, and I think in our own practices, is that really, if you don't do the best operation the first time, patients sort of fall into this vortex of recurrence after recurrence of hernia, and we really want to get them out of that sort of incisional hernia cycle and give them a durable repair. And this is an example of that. This is a 57-year-old, very high-level pharmaceutical executive who had, unfortunately, perforated diverticular disease, had a Hartman's, had a hernia, had reversal hernia repair, had a recurrence, had another hernia repair, and now has a recurrence. So she's now desperate, as she is a third-time recurrent painful hernia. Socially, it's been debilitating for her. She's lost a ton of work. She lost her job, and she's desperate to have a durable repair. So I think in many ways we underestimate the impact that this has on patients. And when I see patients, both for a lot of conditions, I said, listen, you can't let this condition be an anchor for you and hold you back for the things you really want to accomplish with your life. And in the world of hand surgery and the world of lower extremity reconstruction, there's the concept of the killer Ds, right? You see many patients with upper or lower extremity injuries, and they fall into this cycle of depression, disability, drugs. They can't work. And I think the same is true of abdominal wall. Many of these patients have a similar scenario, and we want to get them out of that cycle and get them back to their life. We have started to do some patient-reported outcome data in our hernia patients. So we give them quality of life surveys when they come in during their first clinic visit, and then throughout their course after treatment or postoperatively, we give them quality of life surveys as well. And looking at the surveys, the one thing that I did not appreciate fully is how much of a disability patients attribute to their hernia. It's a significant amount of disability that they feel with an abdominal wall defect. So how do we want to set ourselves up for success? And I'm from Philadelphia, which has more lawyers per capita, I think, than any US city. So if you type in these 4 letters into any search engine, MESH, M-E-S-H, almost always what comes up in any major city is basically class action lawsuits against MESH. So many patients who are coming to see me to talk about their hernia, and I say the word MESH, instantly they're a little anxious about it. But I think the important thing is to educate our patients regarding surgical technique, how we're going to fix this hernia, and the importance of MESH. And I actually have some PowerPoint slides that I show patients recurrent rates with and without MESH, and they sort of have an understanding of how important it is. So really, MESH is something that if you're going to enter this world of abdominal wall reconstruction, you're going to have to embrace on some level and figure out how to make it work for you. There are very good studies looking at hernia repair with primary closure versus mesh closure. And there are very few hernia studies that ever make the New England Journal, and this is the one that gets quoted a lot. This is the Lewandijk study, and the one thing that the Dutch do very well is follow their patients long-term and collect data. If you look at some of the long-term randomized trials, many of them are from the Dutch literature with nearly 100% follow-up rate, which is something that we can only aspire to in this country, as we can never approach that. But if you look time and time again at the Kaplan-Meier curves for primary repair of critical size defects, which I would define as more than 4 or 5 centimeters, without the addition of mesh, you're looking at doubling your chance of recurrence really within 2 to 3 years. And I think when you share this with patients and you show them this data, they're much more accepting of the need to reinforce their hernia defect with mesh. And the common themes, I think the truisms in medicine really get carried through multiple studies, through different investigators, through different publications and different trials. And this theme of needing mesh reinforcement versus primary repair of hernia really is one that's carried through study after study, including this followed by Lewandijk again, showing nearly a double rate of repair if you don't, recurrence if you don't add mesh. So this was one of the most recent studies in JAMA, again out of the Dutch literature, and they looked at 3,200 patients retrospectively with a 100% follow-up rate. Again, you never get that in this country. And they look at who got fixed, how they got it fixed, and what they fixed it with. And what you see is open surgery non-mesh had the highest recurrence. Open surgery mesh was second with recurrence rate. And interesting, laparoscopic surgery with mesh had the lowest recurrence rate, which is something that also I did not expect. There may have been some selection bias, and they may have selected out some of the smaller, easier hernias to do laparoscopically, which is why this data shows the less recurrence rate with laparoscopic surgery repair. But the theme is the same. You have to use mesh for reinforcement of critical size defects. So this is a paper that we published about 4 years ago now, and we were sort of interested in the public health aspect of abdominal reconstruction and sort of what happens and what's happening in the bigger picture. And one way to sort of get a picture of that is using the NISQIP data, which is reported by multiple different institutions. So we looked at a 5-year period of NISQIP data, and we looked at folks getting a hernia repair and about 30% of them were having a concomitant abdominal surgical procedure, bowel resection, colon resection, something else. Interestingly, the one finding that was probably the most interesting in this paper was that of patients with critical size hernia defects, only about 57% of them are getting mesh put in at the time of their hernia repair, despite all the data that we just saw that shows that mesh really is preventative for hernia recurrence. So the message is the same. You really need mesh for reinforcement of critical size hernia defects. So again, in Philly, where we're surrounded by lawyers and litigation, I see a lot of patients that are referred to me with complex recurrent defects or fistulae, mesh infection, some abdominal wall disaster that needs to be addressed. And I can't tell you how many times I've heard this one phrase in the office, and that is, my doctor told me I'm allergic to the mesh. And I sort of have to tell them that, well, you're not really allergic to mesh. Unfortunately, you had a mesh infection, and it's chronic and ongoing, and the only way to fix it is really to remove all the prosthetic material and sort of start over. And I try and tell them it's really almost never the mesh's fault. It's really our fault. And I think it's our fault because most times when we have a problem, we pick the wrong product to put in. We put it in for the wrong reasons. We put it in the wrong anatomic plane. Or importantly, and I think this is something that's critically underestimated, is there was poor soft tissue coverage, which led to some wound healing issue, and then wound breakdown or wound contamination and chronic mesh infection. So the surgical mantra that I tell my residents is you got to choose the right mesh for the right indication in the right patient. So this is a patient that had bladder exstrophy as a child. She has a continent appendiceal conduit as a urostomy, and she had a very painful enlarging suprapubic hernia. So we had to revise her urostomy to get beyond this hernia defect. So this is retromuscular placement of a biosynthetic mesh fenestrated for her ostomy. Contaminated field, but we used a biosynthetic mesh in the best anatomic plane possible. Retromuscular sublay, biosynthetic primary fascial closure, which I think, in my mind, is the right mesh for the right reason in the right anatomic plane in the right patient. Same holds true in some of these challenging breast hernias that we see. So we have a very busy breast reconstruction practice, and we just recently looked at all of our numbers for hernia generation after abdominal-based free flap breast reconstruction, and it still stands right around 3%. So if you're doing 500 to 600 free flap breast reconstructions a year, it creates not an insignificant amount of sometimes very challenging hernias that we need to fix. And this is a patient that unfortunately had a mycobacterial infection after mesh reinforcement of her donor sites. So all the prosthetic material out to find the defect, biologic mesh in. Unfortunately, abdominal wall was somewhat destroyed, no retromuscular or preperitoneal space, so I put an intraperitoneal piece of mesh in and then let her recover for a year after she was healed, cleared her infection, and then came back and fixed her in a more durable fashion. Right mesh, right reason, right place, right patient, and hopefully have a good outcome. So when I was a general surgery resident, laparoscopic hernia repair was sort of just coming into its full being. So as my senior years as general surgery resident, I did a lot of laparoscopic ventral hernia repair and also hernia repair in general. And I remember the concept being drilled into my head of this tension-free repair, and we would sort of lay in this piece of mesh that would just sort of sit there with no tension at all. And I think that was probably a mistake. And I think the strongest thing you're going to put in a patient in hernia repair is the mesh. The mesh from a tensile strength standpoint is very high, and in many cases, many-fold the tensile strength of the native abdominal wall. So I think if you can tension the mesh physiologically and detension the fascial closure, there's only a certain amount of time you need that mesh to be under physiologic tension to allow the fascia to heal. And in many ways, you probably don't need the mesh for long term, which is why the concept of the biosynthetics becomes more appealing. So I think the concept of tension-free repair is not necessarily valid, and we really want to load the mesh and take the tension off the fascial closure with the mesh to allow the fascia to heal primarily. I think when you look at folks who are having hernia repair as well, the one thing that also holds true throughout the literature is your first time fixing these patients is the best. Every time you're fixing their recurrence, their risk of recurrence gets higher. And if you look at this paper that was published in JACS from 2015, we see exactly that. Primary ventral hernia, about a 37% recurrence rate. But if you go down the line, second hernia, third hernia, the recurrence rate again goes up. And this is this vicious cycle of recurrence that we want to get patients out of. If you look at the major conclusions from this study, really what you want to do is reduce your surgical site infections, surgical site occurrences, meaning any soft tissue healing issue. If there's a problem, you look at those hernia recurrence lines and your soft tissue healing complication lines, they're essentially parallel lines that go up directly with each other. So you really want to minimize your soft tissue and wound healing issues postoperatively, which is why as a plastic surgeon, you really don't want to underestimate the importance of the soft tissue envelope of the abdominal wall when you're looking at these patients. Now, unfortunately, a lot of patients with symptomatic ventral hernias that we see in Philadelphia look like this, and I'm sure Seattle is no different. So the obesity epidemic in this country really has created a challenge for us as reconstructive surgeons approaching these patients on who we're going to offer surgery to, and is there a BMI at which an inflection point is such that we should just say, no, you have to go lose weight. You have to try either non-surgical means of weight loss or refer them to a bariatric surgical program to try and lose weight. The issue that we run into is many of these patients with intra-abdominal disasters have an abdomen that is not amenable to any type of bariatric surgical intervention. So there is the prospect of doing their bariatric surgery and fixing their hernia at the same time, but that carries with it significant risk. And if you look at the obesity epidemic, these are numbers actually from the CDC. It's only getting worse as time goes on. So I think this is something that certainly is going to get worse and doesn't get better. And many times when we see patients in the office, we'll tell them, well, you have to stop smoking or you have to lose weight before we'd consider you a reasonable surgical candidate. And I think early on in my practice, I would say these things, but I didn't really give the patient a means to accomplish them. And I sort of realized that even though I was telling them to do it, I didn't help them do it. So now I'm very clear that we have a non-surgical weight loss program, we have a surgical weight loss program, we have a smoking cessation program, we have consultation with the dietitians and nutritionists, and I send them to them, or at least give them the means to accomplish what I'm telling them I want them to do, instead of just sending them on their way with sort of some ill-defined goals that they don't know how to accomplish. Not only do I have my own busy abdominal wall practice, but I help a lot of my colleagues sometimes with some challenging abdominal wall issues. And many times I'm called into the OR and they're about to do an abdominal-based surgery. They say, I don't know where I should make the skin incision. And as plastic surgeons, you know this already, and I tell them one simple thing. To avoid wound healing problems, just think where the blood supply is, coming to that tissue that you want to heal before you touch the knife to the skin, and that's the incision you want to make. I think one of the main differences approaching the abdominal wall from a soft tissue standpoint as a plastic surgeon from when I was a general surgeon is that I do a lot of transverse incisions. I think the transverse incisions can minimize your perforator dissection and in many ways sometimes limit the dead space in terms of dissection or defining the abdominal wall. So a very low threshold for making a transverse incision across the abdominal wall. There are some patients who need their hernia fixed for symptomatic reasons, so we sort of bite the bullet despite their body habitus and do the paniculectomy at the same time. And when I first started in practice, one of the senior partners in the practice, his office was next to mine, and when you're sort of getting going, you're not sure the nuances of practice, and I saw some of these patients, and they said, well, you have to write a letter to the insurance company to get this part approved for the surgery. I said, okay, and he gave me a copy of his letter. And the letter essentially said, we want to do this paniculectomy to reduce your chance of wound healing problems and postoperative soft tissue complications at the time of hernia repair. So I did this for a while, and I saw these patients back, and I thought, you know what, I'm not really sure we're doing these patients a favor in terms of wound healing and at the time of their hernia repair, doing their paniculectomy at the same time. So we did what anyone else would do who was a little bit curious about it. We went back and queried the NISQIP database and said, well, what happens if we're doing paniculectomy concomitantly with ventral hernia repair? And we found that, well, it really is no panacea. And if you look at the outcome of these patients, when you control for all other factors, paniculectomy was independently associated with increased wound healing problems, unplanned return to the OR, deep venous thrombosis issues, and medical complications independently of everything else. So paniculectomy certainly was no panacea. I think for some of these patients, we need to do it to get to the abdominal wall, but it certainly doesn't reduce the wound healing complications like I thought it would. The other interesting thing is if you do paniculectomy and component separation together, that's also independently associated with increased risk of soft tissue healing and wound problems afterwards, probably because we do a little more undermining than we normally do when we do a component separation, when we ligate some of those perforators resulting in wound healing issues. So part of talking to patients about approaching the abdominal wall is giving them a realistic picture of what they can expect in terms of their risk calculation of, well, I think your risk of recurrence is this, I think your risk of a wound healing problem is this. So we generated a number of risk scenarios and score scenarios where we can say, well, you have diabetes, you're overweight, you have COPD, your risk is 18, and I can show them your risk with a score of 18 you put yourself at about a 20% risk of a wound healing issue. And some of this data has been incredibly helpful to really tell patients in real terms. I think 25% of the time I can pretty much guarantee you're going to have some wound healing complication afterwards. And you can see these risk factors, they add up pretty quickly for patients, so it's not an insignificant risk for them. So as a plastic surgeon who also does microsurgery and really relishes that soft tissue closure of the abdominal wall, well, what if there's no soft tissue to close? What if there's nothing there? And I see a number of these patients each year, and the inability to really close anything. They have an open abdomen. It's an abdominal disaster. There's no means of stepping back and putting a tissue expander in some of these patients. They have ongoing enteric drainage or leak. These are patients really who are, I call them soft tissue cripples, because there's no meaningful way going forward to fix their abdominal wall without some soft tissue coverage. This is a young patient who unfortunately necrosed his abdominal wall after liver transplant and ended up needing free flap reconstruction. But if you look at the reasons why we do free flap reconstruction of the abdominal wall, it's mostly trauma or tumor in general, or some downstream sequelae of some previous surgery that they had. Pretty much everyone ends up getting a free vascularized anterolateral thigh flap with vascularized fascia on top of mesh as their primary soft tissue coverage, and the addition of mesh underneath. Almost all of them are soft tissue cripples and have some unstable wounds. So when I looked at this data, we were still using dermal-based biologics, which we've sort of transitioned away from now, but at the time everyone got a dermal-based biologic. Sometimes the donor vessels for free flap reconstruction of the abdominal wall can be quite challenging, and I've used all of these, the inferior epigastric, the mammary, we've used the femoral, the lateral femoral circumflex, and we've used vein grafts to sort of get our way out of trouble. And I've also learned a few lessons along the way that I'll share with you. This is a patient who there was no way I was able to close his skin in the operating room. I told him, I'm either going to close you at the time of hernia repair, or we're going to have to do a free flap. And sure enough, this is the way he looked on the table in the OR. You can see his small fistula in the lower midline that's draining. This is the downstream sequelae of a damage control laparotomy with skin graft essentially on his liver and small bowel. And this is how he looks after anterolateral thigh free flap reconstruction, bridging biologic mesh, and abdominal wall reconstruction. This is him at about 2 years now, and he does not have a hernia. I tell all these patients with a bridging biologic reconstruction, I expect you to get a hernia at 1 year, and if you don't have it, then it's a win-win. But so far, he is hernia-free. I've learned some powerful lessons along the way, and this is a patient who had pedicle tram flap reconstruction of her breast and ended up with chronically infected mesh and had probably more operations on her abdominal wall before coming to see us than any patient that I've had in my practice. She was truly a soft tissue cripple. So we did our algorithm for free flap reconstruction of her abdominal wall, bridging biologic mesh, free flap reconstruction, and my usual choice of donor vessels was still the inferior epigastric at this point. But we know making that hole through the anterior rectus sheath below the arcuate line, you can't close it because the pedicle is emanating through it. So you leave them a potential spot for eventration. So she certainly eventrated her intra-abdominal contents through that spot, and I admitted her no less than 3 times with intermittent partial small bowel obstructions through that eventration, which eventually forced us to operative intervention. The powerful lesson learned here is that usually when we go back and elevate a flap, we're not really worried about the pedicle because there's enough inosculation from the surrounding wound bed to keep the flap alive. That's not true for the abdominal wall because the wound bed it's in contact with is actually the viscera. So there's no vascular ingrowth from the underlying viscera, so you're really dependent on just skin-to-skin contact, which is not enough to carry the flap in and of itself. So sure enough, when I elevated this flap to fix a recurrent hernia, I ended up necrosing about more than 1/3 of her flap and left her with exposed mesh that then had to come out. Thank God we're all born with another thigh. So we went for round 2 for an anterolateral thigh flap. And these patients, when they've come back for their secondary hernia repair underneath their free flap, I now don't elevate the flap anymore. I do it what I call through a hybrid approach. I do it through a minimally invasive with ports and try and don't elevate the skin of the flap at all anymore and use a needle passer and put a big intraperitoneal piece of mesh in these patients for hopefully durable abdominal wall reconstruction. This is her after her second anterolateral thigh free flap plugged into her femoral vessels, and she's now about a year out with a stable abdominal wall. So I want to change track a little bit and just talk about anatomic position and where we put the mesh. And I think this is something that I didn't appreciate until I was probably a few years into practice, the importance of the anatomic plane of mesh placement. And this is sort of my own schema of where do you put the mesh in terms of fascia closed or fascia not closed. And I think invariably, whenever you cannot close the fascia, your hernia recurrence rate is astronomically going to go up in these patients. You always want to achieve primary fascial closure to some degree. And I think when you look throughout the mesh, as we said before, the things that are true get carried through multiple studies independently. And the one thing that holds true really is a retromuscular position of mesh. And I think that's really been borne out in multiple well-studied, controlled studies throughout the literature, in both the plastic surgery literature and the general surgery literature. And if you look across all degrees of contamination, across all different kinds of mesh placement, if you're able to develop and put mesh in that retromuscular space, your risk of recurrence is quite low. And that's true even in degrees of contamination. So in patients that have a one-stage operation in a contaminated field where you're putting in a retromuscular biologic mesh or biosynthetic mesh, these patients will have a much better chance of not having a recurrent hernia than if they had intraperitoneal mesh, which was something counterintuitive when I first started in practice, but holds true throughout our own data and everyone else's published data. And if you look at the data from, this is a paper from Mike Rosen from Cleveland Clinic when he was still putting in dermal-based biologics. If you look at contaminated cases, putting in a piece of dermal-based biologic in the retromuscular space, it's about 24% recurrence rate, which is the lowest in that series. When you compare it to intraperitoneal mesh placement, it was much, much higher for these patients. And this is carried through multiple studies in the literature. And I think when you look at, well, what does that plane do for us? And I think as plastic surgeons, what do we do when there's something that we really want covered or incorporated, or there's something exposed that we need to cover? Well, we usually cover with a flap, a vascularized flap, a piece of muscle, something else to get it well integrated and covered with vascularized tissue. And that's really what we're doing. You're basically putting a piece of mesh in a well-vascularized plane. You're shielding it from contact with the viscera. You're putting it in a physiologic plane where it can bear the stress against the abdominal wall, and then closing the fascia and the autologous myofascial rectus muscles over the top of it. And doing that in the retromuscular plane far and away is the lowest risk of recurrence through multiple studies, both across all degrees of contamination. So I call it the privileged space, and this is actually a drawing that David Lowe did for us for one of our publications of insetting mesh behind the rectus muscles and then closing the fascia primarily. And I call the posterior rectus sheath the most expensive real estate in the entire abdominal wall, because if you can really preserve that posterior rectus sheath, you're setting yourself up and your patient for the lowest recurrence rate you can get. So many times when we're doing lysis of adhesions, you really want to preserve that posterior rectus sheath at all costs. And if you look at retromuscular mesh placement in terms of very well done studies, again from the Netherlands, the sublay really has the lowest long-term risk of reoperation, 12% versus 16%, and the lowest risk of recurrence in comparison to other anatomic positions of mesh. So really we want to develop that retromuscular space to put our mesh in. So this is really, in my world of hernia repair, this is sort of the ideal patient, thin, non-smoker, otherwise healthy, single stab wound, small bowel resection, now with a hernia at a year from her laparotomy. Now we're going to fix her. So we close her posterior sheath primarily, put a piece of uncoated synthetic in her posterior rectus space, and then close her fascia primarily. I did an anterior component separation for her at the time. This is a little bit of an older case, which I probably wouldn't have done out of the gate. Now I'd probably do it initially transversus abdominis release. But when I'm doing the lysis of adhesions, or one of my general surgery colleagues is doing the lysis of adhesions, there's that old surgical mantra, better to leave a little bit of peritoneum or posterior abdominal wall on the bowel than vice versa. And I say, it's not sure that's really true, because the posterior rectus sheath, in terms of what we really want to accomplish with this operation, which is a retromuscular mesh placement, we really want that posterior rectus sheath to be intact. There's no better surface for the bowel to be in contact with than a peritonealized surface. It's biologic Teflon for the bowel above all else. So you really want to try and get it closed primarily if you can, and shield your mesh. And I think everyone in this room has probably been in this plane and done this, but the dissection actually can be quite rapid. We start anteriorly, raise that retromuscular space. It's quite easy. And even in patients who had multiple previous laparotomies, once you get beyond the midline, that space usually opens up into a very areolar plane. And we have this very well vascularized retromuscular space to put mesh in. So what happens if the posterior sheath is gone? So you've opened up, you've looked at your posterior sheaths, and there's no more posterior sheath, and you really want to do a retromuscular repair. Well, you can reconstruct the posterior sheath. And we've done this on a number of occasions, and I think the mesh is your mesh of choice. It's going to be next to the bowel, so most of us will use either a dermal-based biologic or a coated biosynthetic, or you can even use Vicryl with this. Your goal of this piece of mesh is really allow recreation of this retromuscular space and reconstruction of the posterior sheath and allow a retromuscular sublay. And what you want for that piece of mesh reconstructing the posterior sheath ultimately is to be peritonealized. You want it to be a peritonealized surface in contact with the bowel and shield your mesh from contact with the underlying viscera. And this is a patient who actually we saw with multiple recurrent hernias that I shared with you in the past, that 57-year-old woman who had multiple hernia repairs. I really wanted to do a retromuscular sublay for her. Unfortunately, her posterior rectus sheath was absent. This is a dermal-based biologic reconstruction of her posterior sheath, and then an uncoated mid-weight polypropylene in the retromuscular space and primary fascial closure, and she has a durable hernia repair at 2 years out. So we went back and looked at our experience of, well, is reconstructing the posterior sheath, does it confer the same recurrence rate or less of a recurrence rate than the normal retromuscular sublate patients? And it's not a large series. What I can tell you is if you reconstruct the posterior sheath and you're able to get a piece of mesh in the retromuscular space, it yields essentially the most beneficial recurrence rate compared to intraperitoneal mesh placement or other means of mesh placement. So even if you strike out and the posterior rectus sheath is not intact, there are means to reconstruct it. There are some patients where the whole thing will just be gone. The whole surface over their posterior abdominal wall has been stripped away, and those are patients that you just can't do it, and they end up with intraperitoneal underlay. So it's feasible and really can lead to equivalent outcomes in terms of hernia recurrence compared to standard retromuscular sublay. So this, of all the factors besides mesh placement, is probably the most important. And this is where, as plastic surgeons, we get called upon to help out, and that is closing the autologous fascia really is protective for hernia recurrence. And there are very few true laminar structures in the human body, but the abdominal wall is one of them, and we're really able to take it apart into its component parts based on its blood supply and its innervation. And if you look at what's been done in the past, this is a book that I have that was published by Mark Ravitch from 1969, and it's a textbook of hernia. I bought this when I was a general surgery resident because there were some patients that didn't want mesh for their inguinal hernia, and I thought it would just be a good reference for the old Obesity and other non-mesh hernia repairs. But looking through this, you see the component separation has really been done for a long time. This essentially is a component separation done circa 1969. They didn't call it that. In these days, it was just called relaxing incisions until, Oscar Ramirez came along. And, the old phrase that genius steals from other people, he kind of borrowed this because the concept was already out there. What Oscar Ramirez really did when he published this paper, he worded it in terms of plastic surgery nomenclature, taking the abdominal wall apart into its component parts based on its blood supply. And that really was his significant contribution. So he turned the abdominal wall into myocutaneous external oblique flap and essentially a bipedicle myofascial rectus advancement flap. He also made an incision through the posterior rectus sheath in order to gain midline fascial advancement, which in this day and age we don't do because we know the benefits of retromuscular mesh placement. So the true Ramirez component separation, we don't do in its purest form anymore. So why do we do external oblique release? Well, we do it for a number of reasons. We do it because we want to close midline autologous fascia, but in patients who have lack of domain or loss of domain of their visceral contents, it can also increase your intra-abdominal volume to able to get everything back in, because sometimes getting everything back in can be one of the most challenging parts. So this is a very elegant study by Greg Dumani at Northwestern, and he looked at CT volumes of patients who had external oblique release pre- and post-op release and showed that there's a significant increase in intra-abdominal volume and expansion that allows you to reduce the visceral contents back into the abdomen without undue pressure. So external oblique release in a standard fashion does two things. It allows us to get the fascia closer and also increases the volume. And in terms of dictation and billing by strict letter of the law, you are making the abdominal wall into flaps. You're basically making a tried and true flap at the abdominal wall, which has been around forever, turning the abdominal wall into myocutaneous external oblique flap and a bipedicle myofascial rectus advancement flap. TAR, transversus abdominis release, really has sort of been the newish kid on the block that's been gaining in popularity. And this is sort of the plate from Netter that we all sort of have burned into our memories from medical school and from general surgery residency. The only problem with it is, I think we all realize now, it's really not anatomically accurate because it really doesn't portray the distribution of the muscles in the posterior rectus sheath adequately. It would have you believe that the posterior rectus sheath essentially is just the fascial contribution posteriorly, which is not true. And Howard Langstein sort of put this into very well-defined terms in a recently published paper, and this is such a well-done, well-thought-out, sort of easy study that it's one of those things that you wish you had done it. So he went back and looked at CT scans in patients getting CT scans for something other than a hernia repair or abdominal surgery, and then mapped out the transversus abdominis in the posterior rectus sheath and showed that, sure enough, there's a significant contribution of the transversus abdominis in the posterior rectus sheath, significantly superior in the abdomen, and by the time you get to the level of the umbilicus, that contribution is essentially absent. And this is what we see clinically when we're staring down at the posterior rectus sheath that we're dividing when we're doing our transversus abdominis release. So the problem all those years with the Netter plates is that they weren't anatomically accurate. So when we do a transversus abdominis release, this is really what we're doing. We're in that posterior rectus plane anyway. We can now develop a preperitoneal plane to allow you to put an enormous piece of mesh. This plane will allow you to essentially go from psoas muscle to psoas muscle and really put in a huge piece of mesh. The tricky part about this is getting in that appropriate plane. As we all know, the innervation of the abdominal wall runs between the transversus and the internal oblique, and if you're plane off and you denervate the abdominal wall, you may fix their hernia, but they'll have a dysfunctional abdominal wall, and denervated abdominal wall leads to an eventration down the road, which is what we want to avoid. So when I do this, I typically approach the transversus abdominis up high in the posterior rectus sheath, and then get in that plane where the transversus abdominis is up in the air, allows us to get into that preperitoneal space and develop that plane to allow the posterior sheath to come together. And when you look at the amount of midline advancement you get from a TAR release, it's significant. So when you're not able to close the posterior rectus sheath, and you really want to do a retromuscular sublay, you can do a TAR. The TAR does not give you as much midline anterior fascial advancement as a standard external oblique release, but it can really advance the posterior rectus sheath and allow you to put a piece of mesh in that retromuscular space. So really, in my mind, the power of the transversus is not so much in midline anterior fascial advancement, it's really in being able to close that posterior sheath and perform a retromuscular sublay repair and put a large piece of mesh in. And this, I have to congratulate you guys on this paper and looking at anterior component release in a minimally invasive fashion versus transversus release, and a great paper. And interestingly, the recurrence rate was less with TAR when you guys went back and looked at your data. What I'd want to see in terms of follow-up is when you look at mesh placement, did mesh placement, either intraperitoneal or retromuscular mesh placement, did it affect hernia recurrence down the road, whether or not you did an anterior component release or a transverse abdominis release? So this is what we're looking at when we open up that posterior rectus sheath, and these are the nerves that you see arborizing into the rectus muscle, and these are the things that you really want to protect, because ligating these nerves or boving through these nerves is going to cause an essentially atrophic piece of rectus muscle and eventually an eventration of the abdominal wall. When I approach this, I approach it up high in the abdominal wall, looking at the posterior rectus sheath. And when you're looking down at the posterior rectus sheath up high, you're looking at a few structures. You're looking at the posterior leaflet of the internal oblique. You're looking at the transversus abdominis and the transversalis fascia. And you can go through all those to get into that preperitoneal space in a very slow fashion initially. Once you develop that areolar plane, you can pretty much run with it from psoas muscle to psoas muscle to advance the posterior sheath, allow primary closure, and then ideally put a big piece of mesh in here. So the TAR plane can be quite variable, and when you look how thin it can be in a cadaver as well, it can be quite thin. And really what you want is biologic coverage of your mesh, and this really will allow you to do that. And this is sort of that tedious dissection, what you see in that preperitoneal space, and it can be quite thin, and most of the times when I'm doing a TAR, I'm putting a hole in it somewhere that I'm fixing with a vicryl or something else to allow for closure. Any hole in the posterior sheath, you have a potential space that the bowel can find, get up through the posterior rectus sheath, come behind mesh, and then result in a hernia, a recurrent hernia underneath the mesh that can be very challenging to fix. So what mesh do you use? And there's a lot of different companies, a lot of different mesh out there to be used. And I think there's been a number of ventral hernia working groups and classification schemes to try and help us choose mesh. And all these classification schemes are quite simple. Sicker patients, increasing degrees of contamination, high-risk soft tissue patients, we get away from the synthetic mesh and we trend towards dermal-based biologics and the biosynthetics. I think having put more dermal-based biologic mesh in human beings probably than almost anyone at this point, I think there's significant shortcomings to them, and I think you're going to see the dermal-based biologics go away in a number of years and be replaced by the biosynthetics just from their better handling capabilities, their better bacterial clearance properties, and their strength profile over time. So I think the mesh types in terms of synthetic and biologic, the synthetic far and away is much cheaper. The biologics tends to be much more expensive as most of them are animal derived. The biosynthetics usually are non-animal derived. But the biosynthetic mesh really has some characteristics which sort of are in between. They can tolerate contamination pretty well, they handle like synthetics, and they're going to last longer than dermal-based biologics. So when you look at cost, and a lot of these cases can be quite expensive. When I told the administrators at Penn I want to have a hernia center, they said, great, send us your data on all your hernia repairs for the last few years and we'll look at it. So they want to know, are these cases profitable? Are we making money from them, or are we losing money on them? The interesting thing is most cases there's a profit margin. Most cases are sort of the middle ground is break even, but there's a lot of cases that are extraordinarily expensive, and these are sort of some of the abdominal wall disasters. So when you look at the cost of the initial repair and some of these costs of readmissions, these things add up. And so people are paying attention to what you're using in terms of your cost per case. And some of these mesh products, particularly the dermal-based biologics, can be quite expensive when you're putting them in. I don't have enough bravado to put synthetic mesh in contaminated fields. I know some people have done it, and I think the data that came out of Carbonell's paper from the Journal of the American College of Surgeons shows that you can put a macroporous lightweight polypropylene in contaminated fields in the retromuscular space with good results. I'm not that brave to put synthetic mesh in contaminated fields. In my hands, any degree of contamination ends up in a biosynthetic or a biologic. Even though the data for this study was quite good, when you look at the patients that did the best in the study, not a surprise, they were all retromuscular sublay with macroporous polypropylene mesh. The word on the street is that a lot of these patients have had their mesh removed, secondary to increasing incidence of mesh infection, which is, even in their published series, at a relatively low rate of follow-up, was still significant at 26% in clean contaminated, 34% infections in contaminated, 7 recurrences and 4 mesh removals in a relatively short period. And you sort of expect that extrapolating going forward to be even worse over time. There's no doubt that biologic mesh is expensive, but what's probably most expensive is readmission. So you have to balance that fact if you're putting in a piece of synthetic in a contaminated field, that the patient's going to come back with recurrent mesh infections. So you're not able to use the synthetic meshes all the time, and I think the development of the bioprosthetic mesh has really almost allowed a plane shift in abdominal wall placement. I used to shy away from onlay mesh placement because there really wasn't a great mesh to use before. All the dermal-based biologics are incredibly seromagnetic in the subcutaneous plane. I don't want to put any type of synthetic mesh that's going to be permanent in the subcutaneous plane, but the biosynthetics have really allowed onlay reinforcement of the abdominal wall. And what I've done for very high-risk patients is retromuscular sublay or intraperitoneal mesh placement, and then an onlay biosynthetic mesh reinforcement on our high-risk, immunocompromised, multiple recurrent hernias as a sandwich repair. I don't have long-term data on these patients, as I've only been doing it for about a year, but so far we've had good luck. And this is the concept of the mesh needing only to last long enough. And for the biosynthetics, they're not going to stick around. And if you remember some of those slides that we talked about earlier, even putting synthetic mesh in patients, you still ended up with a 20% roughly hernia recurrence rate with synthetics. If you can leverage the biosynthetics and get a similar recurrence rate and not have a permanent foreign body embedded in your abdominal wall over time, I think it would be the ideal. I think some of the newer biosynthetics, particularly poly-4-hydroxybutyrate, that's woven into a mesh, has had some promising results. And when you look at it head-to-head in series compared to the dermal-based biologics, it's cheaper, less seroma, easier time to drain removal, lower rate of reherniation than the dermal-based biologics. So I think the biosynthetics are here to stay, and I think they're going to become a more predominant use in our practice, and much cheaper, unquestionably, than the dermal-based biologics. So what about using poly-4-hydroxybutyrate biosynthetic in some high-risk patients? And this is the patient population I was talking about, potentially replacing some of the synthetic mesh. And when you look at where this mesh is placed, what you see, it has a little bit of a plane shift. Retromuscular, intraperitoneal, onlay, and the onlay really has gained some traction here in terms of the amount of patients that had onlay hernia repair. And I think when you look at hernia recurrence across the board at 9% with relatively 18-month follow-up for biosynthetic, it's pretty good. It's pretty good. So I think, for many of these patients that are high risk, I think we're going to see a shift away from synthetic mesh and increasing use of biologic and bioprosthetics. So clean high-risk patients such as this, multiple hernias, old, number of comorbidities, relatively low BMI, 31, not a smoker anymore, not a diabetic, relatively average defect size, 275 square centimeters. This is a patient who's relatively high risk. So this is, in my hands, this is a perfect biosynthetic patient. Get her fascia closed with an external component separation and put a biosynthetic in her with a good result. We know from very well done studies that any type of soft tissue complications increases your risk of hernia recurrence, as does morbidity. So we really want to limit the chance of morbidities, and we know the soft tissue is vitally important in handling the soft tissue to reduce your chance of a surgical site recurrence or surgical site infection, because you don't want to end up with this in the setting of having put in a synthetic mesh. So a lot of these challenging patients from a soft tissue standpoint, we really want to leverage the soft tissues to our advantage and minimize the chance of a mesh infection. So a lot of these very high-risk patients, I think, are good candidates to shift away from synthetics to the biosynthetics. I want to take just the last few minutes to talk about something that really John Fisher, who when he was my resident, has sort of really forged ahead with, and that is essentially prophylactic mesh augmentation at the time of their initial laparotomy. So they get their initial laparotomy, high-risk patient that you estimate has a significant chance of getting a hernia. Before they get the hernia, you put a piece of prophylactic mesh at the time of their primary operation. And this is the paper that we published from Annals going through our own Penn institutional data, looking at who gets a hernia, and this is sort of their risk calculator, and you can see that the standard things, BMI, nutritional status, pre-op radiation, and when you see the risk score that gets created, that risk score adds up very quickly, and you can quickly realize that a lot of these patients are at significant risk of getting a hernia. So why don't we intervene at the time of their primary operation and not subject them to a hernia repair down the road, which can be quite costly for them. So we really want to fix them with prophylactic mesh before they develop their incisional hernia. And really the onlay is the perfect plane for that reinforcement. And the two things that have happened, I think, that will allow us to do this really is acceptance of other specialties and the development of biosynthetic mesh that allows us to reinforce the abdominal wall in an onlay position in a quick, easy, durable fashion with hopefully reduction in rate of hernia occurrence down the road. So this is a CPT code that really John Fisher was instrumental in getting approved for us. It's a tracking code for prophylactic mesh augmentation 0437T that you can use. You don't get reimbursed for it, but it is a tracking code for prophylactic mesh augmentation if you wanted to use it. So I think with that, I will say thank you for your time and attention. And again, thank you so much for having me here, and I'll take any questions that you may have.
Fantastic. Are there any questions? You're kidding.
See, again, I'm a pretty visual surgeon, but staged approaches, if you're missing the posterior sheath and you're going to be doing a posterior sheath reconstruction, do you ever stage that before you put your sublay? Like, it seems like you do it simultaneously, but is there other situations?
No, always simultaneously. So we're doing the posterior sheath reconstruction and then putting our retromuscular sublay in and then getting some degree of primary fascial closure. I think the staged patients are the one where you see them and they have multiple draining fistulae, they have a big hernia, they know they need a bowel resection, you know you're never going to be able to get the fascia closed, and I basically tell them, listen, you're going to need at least 2 operations. You're going to need restoration of bowel continuity, you're going to need us to get the fascia as close together as you possibly can, get stable soft tissue coverage, and then when you get your hernia recurrence, then we'll fix you in a more durable fashion, hopefully at a year. So I tell them the big predictor is really whether or not we can close your autologous fascia, because any biosynthetic or dermal-based biologic in a bridging fashion, in my opinion, is 100% hernia recurrence. So they're going to get a hernia back, it's just a question of when. Yes. So I think if you look at abdominal wall transplantation, most of them are all in the setting of multivisceral organ transplant patients. So they've had short gut, some other intra-abdominal disaster, and they now need liver, small bowel transplant, and there's no soft tissue coverage of the abdominal wall. Those are typically the patients that need abdominal wall transplant. The patients that we see at Penn, we don't have a small bowel transplant program, so I don't really see those patients. Occasionally, we'll see a patient who had typically a liver transplant that necrosed their abdominal wall that would benefit from a transplant. We've had several over the years, and I work with the transplant surgeons very closely on a number of other endeavors, and they would consider abdominal wall transplant in that situation standard of care. So there have been a few situations where I've said, well, let's go get an abdominal wall at the time you procure the second liver and do it, but they've always gotten a little bit cold feet when I've suggested it. And so we've always gone back in some of these patients to standard reconstructive means, which is bridging biologic and or free flap reconstruction or some means of closure. Yeah.
So as the home of the damage control surgery, do you have any data comparing how much that approach to trauma has contributed to your workload to other places that don't use it as freely?
Yeah, so the question is, why don't we close the abdomens in a more expeditious fashion as opposed to leaving them open? And I think Penn really is one of the birthplaces of the damage control laparotomy. And I think sometimes old habits die hard. And I think sometimes the rate limiting factor for a lot of these patients is the ability to actually close their soft tissue. So it's very challenging when you have all the skin graft on their viscera. So I've tried to convince the trauma surgeons that, you know what, even if we go in relatively early, and even if you put something in, put a Vicryl in, something in, and close the skin, our job down the road will be much, much, much easier. I've gained a fair bit of traction. You know, I think we've definitely changed a little bit, but definitely they tend to prefer the DCA, so we see a lot of downstream effects from that. But they're no question they're more challenging patients.
Keeps you busy.
Yeah. Alex.
Laparotomy incision that you're going to be doing a metacardial repair and you anticipate they need an anterior release. Are you doing that through separate lateral stab incision and trying to avoid connection with your second, or are you doing it?
Repeat the question.
Yeah, the question is, what do we do about the perforators for an external oblique release, and do we do a separate stab incision, or do we preserve them in some fashion? So I always try and preserve them. So I don't usually make separate stab incisions. I just make little tunnels up and down, going from medial to lateral. Some of these patients, though, there's no way to keep the perforators and close the skin, just because you need so much skin advancement to get things closed that you just have to sacrifice the perforators. But we always try and save them. You know, the one downside against standard external oblique release is that you can render the midline skin relatively dysvascular if you sacrifice the perforators, which leads to wound breakdown and hernia recurrence.
Oh,
Yeah.
one more question in the back.
You alluded to difficulty finding vessels for pre-flap reconstruction. Do you have an algorithm that you can follow first choice, second choice, third choice for finding those vessels?
So I will, my first choice, if it's anywhere in the upper abdomen, I usually use the mammary. And almost always we're doing an anterolateral thigh flap. If you look in our series of free flap reconstruction of the abdominal wall, there's only one latissimus flap. And that patient, unfortunately, had a perforator injury and had one leg. So we ended up having to do a latissimus flap. But for the most part, we're doing anterolateral thigh flaps with vascularized fascia for everyone. So the advantage is the pedicle is really long. And we're so facile with the mammary from free flap breast reconstruction, it's so reliable that usually I'll go to the mammary, usually the right side, just because the vein's better on the right. If the hernia is down low, I don't use the infraepigastric anymore, just because I'm afraid of what happened to that patient that I had and not being able to close the anterior fascia. So what I'll do is either just go to the femoral if I can reach, or if I can't reach, I'll just extend the branch to the flap with vein grafts. So I'll basically just interpose vein grafts to move it up onto the abdominal wall where I want it. So basically, put the vein grafts at their origin to your flap vessels from the profunda, and then put that on the abdominal wall, and then just cut the flap and move it up.
Steve, thank you so much. Fabulous talk. Unfortunately, this is being recorded for UWTV, so that those who aren't here today can see it later. But I think this is a great example of what plastic surgery is. Developing creative solutions to difficult problems everywhere in the human body. And our future as plastic surgeons is just that, helping to be the problem solvers for everybody else's most challenging problems. And this is a fabulous example for that. Thank you so much.
Thank you so much.
And I have a token of gratitude from us for being our 25th annual Peter K. Buehler Lecture.
Thank you.
Outstanding.